Three, two. Good morning from Miami Beach. This is Dr. John Bennett. This is the home of Neurosurgical TV. We've been televising this for years. The China Neurosurgical Journal webcast. It's a bi-monthly webcast featuring the journal, as well as an outside speaker like Juan. I know Juan, for a while, he does a lot of webcasts in Spanish, in Mexico and Latin America. And I'll let Juan Lee do the formal neurosurgical introduction. Okay, Juan Lee, how you doing?
Sure, yeah. Thank you, John. So now we just start our bi-weekly Chinese Neurosurgical Journal webinar. And today we, as regular, we have two speakers. One from Mexico, and the other from Beijing, China. So I think another moderator, Professor Bing Xu, now he's in Little Rock, Arkansas, to attend the seminar organized by Dr. Al-Mafti and Dr. Ali Christ. So maybe he will be he will join us later, cause now I think it's 4 a.m. Sunday at his time zone. Yeah,
and, that's not early for
okay.
a neurosurgeon.
Yeah. Okay. Now, please allow me introduce the first speaker, Professor Juan Amador. From the Dr. Amador from Mexico, and he will talk about endoscopic technique in cranial neurosurgery. So please, Dr. Amador. I think he's one of the most famous neurosurgeons in Mexico. So
yes, he is.
You're very welcome.
Oh, you're muted, Juan. You're muted. Okay. Okay, you're muted, Juan. Unmute.
Yeah, I'm so sorry.
There you go.
Okay. Good.
Yes. Oh, not yet. Perfect. Okay, perfect.
Yeah. Okay. Good morning to everyone, and good night in China. It is a pleasure for me to have this invitation to share with you some aspects of the endoscopic techniques that we can use in cranial neurosurgery. It is very important during the time that I have been neurosurgeon that we need to not to be greedy. We need to be honest in what we offer to the patient. So when we have peripheral visualization of the interventricular cavities, an adequate corridor, and good clinical judgment and experience of the team, we can offer some of the endoscopic intracranial techniques to help the patient, always based in the neurological exam as the basis for success. And this is because after a careful neurological clinical examination, we can order specific diagnostic studies. So as we use in the National Institute of Neurology and Neurosurgery in Mexico to achieve success. Endoscopic surgery, as I told with the Professor Al-Mefti back in 2019, is a tactile surgery in which we use the proprioception in order to visualize the depth of the surgical field. And for that, we must to learn these techniques in the laboratory. There are different techniques in animal models or cadaveric specimens that we can use to become familiar with the endoscopic view that we need to master for these techniques. So in 2004, we established the school-based and neurosurgery program at the National Institute of Neurology and Neurosurgery, and we are using currently the endoscopic-assisted microsurgery, interventricular endoscopy, endoscopic transnasal skull-based surgery, endoscopic port for intrinsic and intraventricular tumors, and also with the endoscopic transorbital skull-based surgery. We need to master the planning of a surgery in a proper manner using high definition MRI, MRB, MRA, angiography, CT scans, so we can become familiar with the surgical corridor before we plan the surgery. Now the optic systems with the 4K HD technology and the Rubina image from stores, we can use these to have wonderful views of the surgical corridor. Currently, there are hybrid microscopes that provides the surgeon with the implement that we can use endoscopy during the neurosurgical procedure, so we can access to different aspects of the surgical field. Also, the fluorescence techniques allow the surgeon to identify tiny vessels in the surgical field so we can preserve them. We perform a pilot study using sodium fluorescein in endoscopic endonasal neurosurgery, and we think this is a very good tool, especially during the beginning of the learning curve. We address that endoscopy is not 3D. We do not have a stereoscopic view. So for that reason, we need to use the perception. And there are currently some systems in the market that try to resemble the 3D view that we have in the microscope. This is also very useful to be used during the beginning of the learning curve. And in that way, we can achieve good results for the surgery, trying to use these systems that try to resemble. But always remembering that the anatomy is the pilot in which we can go from the sphenoid sinus, for example, in the skull-base surgery, as a single procedure. We can extend our approaches to the transteligoid approach, the transmaxillar IPSI or contralateral approach to reach certain lesions. We can go to the anterior cranial fossa. We can use the endoscope also in the transcranial approaches. So in that way, anatomy is always the key factor to achieve success, because the anatomy has no limits. We can go from the pterygopalatine fossa, the median nerve, internal carotid, the branches of the trigeminal nerve. We can go all the way down from the middle line to the lateral part. So why we do that? Because we need to gain for the patient improvement of the symptoms, pathological diagnosis, in order to improve the prognosis of the patient, and always trying to preserve the neurological function. For example, in this case, this is a patient with a recurrent pituitary adenoma in which we perform a Dolench approach to the cavernous sinus, and after opening of the dura mater, we came all the way down to the cavernous sinus using the dorsal corridor. And after using the proper microneurosurgical techniques, we decide to introduce in the surgical field the endoscope, so we are able to visualize directly the layers of the dura mater inside the cavernous sinus, so we can be sure and certain, even with the neuronavigation, that our tumor is being removed totally. This is the entrance of the cranial nerve, and in the middle, to the left side, the internal carotid arteries. So we open the corridor, and we visualize with the endoscope inside the cavernous sinus that the lesion is being taken out, as we can see in the postoperative MRI. So when we treat these lesions with the endoscope assisting the microscope, we achieve views that usually we do not have with the single microscopic view. In this case, for example, a pituitary adenoma could be treated with the endoscopic endonasal approach, but this patient had bilateral paraclinoid intracranial aneurysms, so we decided to perform a right diurnal approach, resection of the tumor, and bilateral clipping of both aneurysms using microneurosurgical technique. What technique can we use for the treatment of intracranial aneurysms? We can use endoscopic-assisted microneurosurgery, and in this case, we perform the dissection of the aneurysmatic complex. We perform a pre-clipping endoscopic exploration clipping the aneurysm with the endoscope, and adjustment of a clip if it is necessary. And after the clipping, we perform post-clipping endoscopic exploration. In that way, we gain integral visualization of a perianeurysmatic anatomy under direct vision. In this case, bilateral MCA aneurysms treated with a unilateral approach through the left diurnal approach. And in the right MCA, we can perform exploration with the endoscope so we can see the blades of the clip obliterating the aneurysm with permeability of the M1 segment and this early temporal branch, as you can see here, with direct vision with the endoscope in an angle that the microscope does not provide to the surgeon. This is another case, bilateral multiple intracranial aneurysms. We perform a right diurnal approach. We took out the anterior clinoid process, and after wide dissection of the basal cisterns, we go to the left sylvian fissure opening, identification of the aneurysm in the contralateral MCA. We perform the clipping. We introduce the endoscope so we can achieve a wonderful view of the complete clipping of the aneurysm. Then we came back to the anterior communicating artery complex. We performed the clipping of this small aneurysm, and also we introduce the endoscope so we can see if there is some remnant of the aneurysm or not. And finally, we came to treat the ipsilateral PCOM aneurysm and also in the MCA. This is another case of bilateral PCOM aneurysms treated with a unilateral left orbitocranial approach. After direct clipping of both aneurysms, we introduce the endoscope so we can achieve direct visualization of the tip of the blades of the clip, as you can see here, with adequate clipping of both aneurysms. Another endoscopic technique that we can use for the treatment of vascular lesions is the endoport. So in this case, with a patient with a distal posterior cerebral artery aneurysm with a parenchymal hemorrhage and ventricular eruption, we use the endoscope. So we insert the endoscope for evacuation of a parenchymal and intraventricular hematoma with navigated endoport. We perform the vascular exploration, clipping of the aneurysm and aneurysmectomy using the endoport-assisted technique. In this way, we can use these endoscopic techniques. We have seen visualization of vascular structures during the treatment of tumor lesions, either for craniopharyngioma, chordoma, pituitaryadenoма, schwannoma, etc. The important is that currently there are a direct treatment of intracranial aneurysms using endoscopic endonasal techniques. Up to now, we have knowledge of around 40 cases worldwide, one of the most important series from Professor Hong from China, and the other one for Gardner. We have also some experience. And as you can see here, some of the patients had a subarachnoid hemorrhage and can be treated using endoscopic endonasal techniques. In this case, a giant mid-basilar thrombosed aneurysm was treated by endovascular therapy, and she developed a huge mass of interaneurysmatic thrombosis with compression of the brainstem, as you can see in the sagittal MRI. So we came to the OR, we performed a wide clivectomy with opening of the aneurysmatic sac. Then we decompress the thrombus inside the aneurysm, and then we close the sac in order to alleviate the compression of the brainstem. We can go to the hybrid OR, and we can have some maneuvers to treat some lesions, as could be the proximal control, the road mapping clipping technique, endonasal clipping, embolization, or even the treatment of meningioma resection in the hybrid OR. We work from the chest to the head of a patient. Endovascular therapy works from the chest to the feet. And in this case, a giant large vertebrobasilar aneurysm was taken to this hybrid OR using endoscopic endonasal approach with neuronavigation. We performed the wide clivectomy, identification of the aneurysmatic sac, the compression of the sac, and in this instance, we can use the road mapping technique to guide the dissection of the surgeon, and we use in this particular case also the interpretive dyna-CT to assess adequate alleviation of the compression of the thrombus mass over the brainstem. This is a very particular case, paraclinoid medial in internal carotid artery aneurysm. We take the patient to the IVDOR, endoscopic endonasal approach with identification of the pituitary gland, the neck of the aneurysm, the carotid, the optic nerve, under a proximal vascular control with the balloon occlusion by endovascular therapy, and complete clipping using this endoscopic endonasal approach for this very particular patient. We need to be aware of the complications of endoscopic endonasal surgery. For example, in this case, a rupture of internal carotid artery with the scissors at the moment of the opening of the dura mater, and we need to be aware how to avoid these complications. And for this, the anatomy is mandatory to guide the neurosurgeon in the surgical field. We can use hemostatic foam to treat some bleedings, particularly of the venous lakes that we can present when we open the cavernous sinus or the basilar plexus. We can use the technology as the neuronavigation, the stimulation of the nerves, as you can see here, during a transcribal approach, or the identification of internal carotid artery using the ultrasound Doppler to see where is the carotid artery in some instances. Most of the times we use the 0 degrees endoscope in endoscopic endonasal techniques. But for some specific regions, such as the cavernous sinus or the petrous apex, we can use the 30-degree endoscope or even the 45-degree endoscope to achieve a complete visualization of the surgical field. To be used in a proper manner, we need angle instruments that can reach the very edge of what we are seeing. With straight instruments, it's not possible, so we need to use angle instruments for this instance. One of the main complications for endoscopic endonasal neurosurgery is the CSF fistula. And in order to avoid that, we perform a multi-layer reconstruction technique using dual substitute, fascia lata, a piece of bone, and on top of all of this, we use an nasoseptal flap. In this way, we can reduce the CSF fistula comparable to the achievements with microneurosurgery using this multi-layer reconstruction technique. The most frequent lesion treated with endoscopic endonasal approach is the pituitary adenoma. And we can define several techniques that we can use to treat the pituitary adenoma because the pituitary adenoma is a multiform lesion. So the most typical case is the central lesion that compresses the chiasm above. So we can come from below using endoscopic endonasal approach with wide opening of the sphinx sinus, wide opening of the sellar region. Then we can open the dura mater and start to dissect the aneurysm, the adenoma, the pituitary adenoma, as you can see here. Most of the times, the tumor is very soft, and we need to take care when the arachnoid of the suprasellar system protrudes to the surgical field, because we need to be very careful not to tear the arachnoid so we can avoid the CSF fistula. For that, we need to be very cautious with the resection of the remaining part of the tumor, preserving always the arachnoid. Otherwise, we can perform the proper multi-layer reconstruction technique. For some functional tumors, we need to use a transglandular technique in which we open the pituitary gland so we can identify the characteristics of that define the tumor. The tumor are usually yellow or white and with a well-defined plane, so we can separate the entire tumor from the remains of a pituitary gland. In some instances, we use cutting the dissection with the scissors to avoid leaving remnants of the tumor so we can improve the quality of life of the patient when we achieve remission. You can see here with the scissors, we're taking the last parts of the tumor, and after performing this technique, we need to assure a proper and adequate reconstruction to avoid the CSF fistula. Another technique that we use is what we call the parainfundibular technique that mainly we use in acromegaly patients, in which we leave just a remnant of the pituitary gland attached to the infundibulum, and with the scissors, we take out all the tumor. And in this case, as you can see here, there is just a small remnant of a pituitary gland attached to the infundibulum. And after this, we require a multi-layer reconstruction technique to avoid CSF fistula. We can go to the cavernous sinus to treat pituitary adenomas, hemangioblastomas, chordomas, some schwannomas that invade the cavernous sinus, and to the petrous apex when we have a cholesterol granuloma, epidermoid cyst, chordoma, some meningioma, or even schwannoma of the trigeminal nerve. The importance is that we need to go to the cavernous sinus when it's needed. Not all the time we need to go to the cavernous sinus. But for example, for the cases of the patients, in our experience, most of the patients with acromegaly need a radical treatment, and we can go endoscopic endonasal, endoscopic transorbital, or even contralateral transmaxillar to achieve an adequate resection of the tumor. We designed in 2016 this a lateral transcellular approach in which the tumor gives the surgeon the surgical corridor to reach the most lateral portion that invades the cavernous sinus. And in our experience, this is a very nice technique to go, for example, in this a female patient of 29 years with no deficit on the visual fields, with acromegaly and invasion of the cavernous sinus. So we go initially to the central part of the tumor. We decompress the central part of the tumor. We put a piece of gel foam over the cavernous sinus. This is a wide opening of the anterior wall of a sella turcica. And after decompressing the central portion of the tumor, then we will go to this lateral portion, as you can see here, and with angle instruments, we go to the corridor that the tumor has already done, and we retrieve the tumor from the lateral part of the cavernous sinus. The cavernous sinus, when it's invaded by tumor, is very amenable to be working. And just at the end of the procedure, when we take out the entire tumor from this area, then we see bleeding from the cavernous sinus as the petrosal sinuses are being adequate decompressed, so we can have reflow of the blood. Small pieces of the tumor that are coming out from the cavernous sinus, and we perform a final inspection of the surgical corridor and adequate reconstruction to achieve a surgical remission. Another case, male, 47 years with acromegaly, large invasion of the cavernous sinus on the left side. We can see here remnants of the lateral wall of the middle wall of the cavernous sinus. So we go straight forward to treat that portion of the tumor with angle aspirator and curettes, so we can achieve a complete excision and remission of the disease in this patient. Look at here, with angle curettes, we are able to retrieve the tumor from the cavernous sinus on the left side. And after this, we can see a protrusion of blood from the cavernous sinus once it is decompressed. And the postoperative MRI shows complete decompression of the tumor. There are some tumors that are rigid, and we need to be very careful to treat these lesions. So in this case, invading the cavernous sinus, at the end of the procedure, we can see the internal carotid artery in the middle of the surgical field, the sellar region to the right, completely decompressed, and the lateral portion of the tumor also completely decompressed using a microsurgical technique to retrieve the tumor. When the tumor goes up to the roof of the third ventricle or the foramen of Monro, we can access to the transtubercular or transplanum approach in order to reach the adequate inclination of the instrument, so this can go to the very top of the surgical field. And for some giant tumors that invade the lateral ventricles, we use a combined endoscopic technique to treat these lesions. So we can use the miniterinal approach with endoscopic endonasal approach, or the extended endoscopic endonasal approach combined with a transfrontal transventricular approach that we have used in lesions like this. Very large tumors that invade multiple compartments in the intracranial cavity. So we come from both sides, transfrontal, transventricular, and endoscopic endonasal approach in the same time. So you can see here some results, adequate decompression of the tumor. And despite of these great efforts for these large tumors, some of the times we can have a small remnant piece of tumor that we can have for observation, radiosurgery, or even planning a new surgery. But these techniques allows the surgeon to have a complete visualization of the surgical field using these endoscopic techniques. From 2002 to 2022, we have learned that the pituitary adenoma is the most frequent lesion to be treated with endoscopic endonasal techniques, and we can go to the cavernous sinus in a very safe manner, and some of the patients will require some combined technique to be treated. Canopharyngioma is a very complex lesion. We can see here, except for the far lateral approach, most of the microneurosurgical and endoscopic approaches that we can use. And this is because this tumor can go to many compartments. In this case, for example, a large canopharyngioma, we use a small transcranial Brock's approach. And then once we open the dura mater, we see protrusion of a encephalic and the cyst. And then we introduce the endoscope and use it as a cisternal endoport. So with by manual dissection, we are able to perform the resection of the tumor using just the endoscope as the visualization tool in this case. We can see here some images of a surgical field with by manual dissection using scissors, rongeurs, and aspirator. We are able to perform complete resection of a tumor, as you can see here. Extracting large fragments of the tumor in this very lateral canopharyngioma, and after performing the closure. So for this case, the endoscope provides a good optic tool to visualize the surgical field because the lateral portion of the tumor was very cystic. So in this another case, endoscopic endonasal approach, we use the transtubercular approach, we identify the pituitary gland, we start to decompress the tumor, look how to preserve the visual apparatus above the tumor, preserving the perforating vessels, and preserving also the pituitary gland in the procedure. After this, we require a careful multi-layer reconstruction technique to avoid the CSF fistula. This is another case. We perform a wide opening in the sphenoid bone, wide dissection of the anterior wall of the pituitary fossa. We go to the tuberculum cilia and even the posterior part of the planum sphenoidale. We open the dura mater, and then we start the peripheral dissection of the tumor very carefully to try to take out the tumor in a sequential manner. In canopharyngioma, it is very necessary to preserve all the vessels. Here we see the basilar tip. We are performing a careful dissection of the arachnoid around the tumor so we can preserve the vessels. And in the top, we can see the third ventricle that has been exposed once we took the tumor out. Multilayer reconstruction using a fat graft to avoid CSF fistula. Another case with a very large component in the posterior fossa. So in this case, we perform a transclival approach. We start the opening of the anterior wall of the sella turcica, then we go to the clivus, so we can take the clivus out, and once we open the dura mater, we decide to perform a lateral transposition of the pituitary gland, so we can access directly to the interpeduncular fossa and perform the decompression of this very large tumor that subsides there. It's advisable to perform a cutting dissection technique to avoid pulling out the tumor, because the tumor can be attached to vascular structures that are very important in this area, particularly the perforating vessels. The result is a subtotal resection with adequate clinical outcome for the patient, so the goal was achieved. In meningioma, there is a lot of controversy. If you see to the literature, the importance is that we perform internal devascularization and decompression of the tumor, and coming from below, the optic apparatus is almost not touched, as you can see here, and we can perceive the infundibulum and the optic system. There is a lot of controversy worldwide about the endoscopic endonasal techniques for the treatment of meningiomas. But for example, in this case, a very central lesion in which located in the clivus, the mid and inferior part of the clivus, we perform adequate exposure of the dura mater after performing a clivectomy. And once we open the dura mater, we see the devascularized tumor that can be very easily approached and separated from the vessels of the posterior circulation, as you can see here. At the end of the procedure, both the vertebral arteries, the basilar artery, and a multi-layer reconstruction technique to avoid the CSF fistula. Today, I think that there are some cases that can be treated with endoscopic endonasal technique, but currently we do not advise to use this technique for anterior floor meningiomas such as olfactory groove, and just for selected cases of the tuberculum cell. We can use endoscopic endonasal techniques to treat fibrous dysplasias in this case, in which we perform the anterior cliendectomy using endoscopic endonasal technique. We can go to the cavern of Meckel, as in this case, very small tumor, precisely located in the Meckel's cave. So we perform a transterigoid approach, going directly to the lesion, starting the opening of the dura mater, the compression of the tumor, and then we go to the posterior part to reach the trigeminal entry of the nerve to the Meckel's cave, and in a fashionable manner, we are performing adequate decompression of the tumor, as you can see here. And at the end of the procedure, the arachnoid of the posterior fossa protrudes to the surgical field, so we perform adequate hemostasis, and then multi-layer reconstruction technique to avoid CSF fistula. The postoperative MRI with complete excision of the lesion. In some other cases, we need to perform combined approaches, as in this case, a transmaxillary and endonasal endoscopic approach to treat this very large part of the tumor that corresponds to a trigeminal schwannoma. As you can see, this yellowish tissue that can be easily taken out using this combined technique. The postoperative MRI with complete resection of the tumor. We can use a contralateral transmaxillary approach to reach the cavernous sinus or even the petrous apex, as we did in this melanoma metastasis. In this case, we were able to perform a careful and complete resection of the lesion using this technique. We can go to the clivus, so we can perform a wide clivectomy to treat lesions such as chordoma, as you can see here, in which we need to be very radical in the removal of the bone, the dura mater, or the cisternal component to have this surgical field at the end of the surgical procedure. So the basilar is just in the mid of the surgical field, but the dura mater that was infiltrated by the tumor has been taken out, as you can see here. Endoscopic endonasal approach for exploration of neurocystic sarcosis can be performed also. We need to use always natural corridors. And for some patients, as in this case, it's a small portion located in the ventral pons with this posterior displacements of the fibers. So we decide to go using endoscopic endonasal approach to treat this cavernoma in the ventral pons. So wide clivectomy, opening of the hematoma, and then start the dissection, and at the end of the procedure, complete resection of the cavernoma. This is another case, a young female patient with a headache and left hemiparesis and hemianesthesia, a ventral pontine cavernoma that was taken to the OR, wide clivectomy, hemostasis of the plexus, of the basilar plexus with the bipolar forceps and surgical foam, identification of the basilar artery. Then we evacuate the hematoma as the first step of the procedure, and then we start the dissection of the active portion of the cavernoma so we can avoid the postoperative recurrence of this lesion with the risk of bleeding in this very critical area. So after resection of the lesion, we can inspect directly the surgical field, performing adequate hemostasis, and then closure in a multi-layer fashion technique to avoid CSF fistula, as we said before. The postoperative MRI and the patient in the postoperative period with adequate resolution of the pathology. This patient, male, 65 years old, with bilateral pyramidal syndrome, with a 6th nerve palsy, was submitted to resection, so total resection of this ventral pontine lesion, which turned out to be a pontine metastasis. There are a few cases of this type of surgery in the literature, but the most important thing is that in 3 of the 10 cases that we found in the literature, there is a CSF fistula. So we need to avoid the fistula using adequate reconstruction techniques. When we go to deep-seated lesions, we can use the natural corridors, as Professor Yashagi showed us. So we can treat this right thalamic pulvinar GBM using a right occipital posterior interhemispheric parasplenial approach. And in some cases, the lesion goes to the ventricular system. And if we use the working channels of the endoscope, we can feel trapped in the surgical field. So we can use also the endoport technique to achieve adequate resolution. Hydrocephalus is the most frequent treated lesions using endoscope in the ventricular system. So as you can see here, the difference using 0 degrees and 30 degrees endoscope for treatment of hydrocephalus, performing adequate third ventriculostomy. We can use, we can use the flexible endoscope, as in this case, to treat intraventricular cysticercosis, but the image of the flexible endoscope is not always as clear as the which one we get with the rigid endoscope. So we advise to use the rigid endoscope for most of the cases, and for very specific cases, we can go to the very inferior part of the fourth ventricle, as you can see here, using the flexible endoscope. We can take out tumors at this subependymoma using intraventricular endoscopic technique. In this case, using bipolar coagulation and forceps, we are able to detach the tumor from the mid part in the septum, and once the tumor is released, we can take the tumor out to the surface, and then we perform adequate resection of the lesion, as you can see in the postoperative MRI. Choroid cyst is another lesion that can be treated very easy with the endoscope. So we perform the adequate resection of this lesion through the working channel of the endoscope using a specific ultrasonic aspirator that we were able to use through the working channel of the endoscope. This was a recurrent case. So here we are using the ultrasonic aspirator through the endoscopic working channel to achieve complete resection of the lesion, as you can see here. So these endoscopic techniques allows the surgeon to perform adequate visualization of the intraventricular system, to perform a wide third ventriculostomy at the end of the procedure. We can see the dorsum cell there, small portion of a tumor that was left behind, so we can take it out with the forceps. And at the end of the procedure, we achieve complete resolution of a tumor. Another interesting case, third ventricle cavernoma, which we use exclusively the total ventricular technique, using the grasping forceps to taking out the tumor, the lesion. And it is a very easy technique once you become familiar with the use of the working channels of the endoscope in an adequate manner, as you can see here. the postoperative result with complete resection of the lesion and the patient in good clinical condition after that procedure. What can we do with the deep-seated lesions? We can go using the endoport. Initially, we use the endoport technique in Mexico to treat intrinsic lesions such as metastases, abscesses, or cavernomas, and later, as we described before, we can use also for the treatment of extrinsic lesions such as craniopharyngioma or pituitary adenoma in a combined technique. It is important to have a proper knowledge of the fiber dissection technique combined with high-resolution MRI tractography to have a proper knowledge of the adequate corridor that we can use in this very simple procedure, small incision in the skin, small craniotomy, 3 by 2 centimeters, with the introduction of an endoscopic port guided with navigation, as in this case, that you can see here. We can treat lesions as profound as 50 millimeters, and the size of the lesion goes from 9 to 67 millimeters. So this is a case, small lesion located in the depth of the frontal lobe. We introduce the endoscopic port using navigation. We go directly to the lesion, then we aspirate the purulent content of this abscess, and then we take out the tumor using bimanual dissection technique to achieve complete resolution of the lesion, as you can see there. We can use it for the cavernoma. We just insert the endoscopic port, very straightforward, using navigation in this case. It is not always necessary, but we have residents, so we have seen the utility of using navigation for these simple cases for the teaching of our residents. So in this case, using bimanual technique dissection, we are able to perform adequate decompression of the hematoma and the active part of the cavernoma, as you can see here, using coagulation, ring forceps, biopsy forceps to achieve complete exclusion of the lesion, as you can see in the postoperative MRI. Another lesion with the endoport, we treat this intraventricular lesion, which turned out to be a central neurocytoma. Note the bilateral management of the lesion with both hands, careful dissection, ring forceps, so we are able to perform adequate decompression of the tumor and then go to the most peripheral part of the lesion, angling, making an angle of the endoport so we can reach the complete surgical field with the small movements in the surface so we can address direct visualization of the lesion using a small endoport as our surgical corridor to go to this very deep seated lesion. At the end of the procedure, adequate hemostasis, we left behind a ventriculostomy to assess ICP in the postoperative period, and the patient went well, as you can see here in the postoperative MRI with complete exclusion of the lesion. The orbit is always a surgical corridor in which we can go and dissect the orbit, the temporal muscle, the frontal and temporal dura mater, and the spinal crest. We can open the meningo-orbital band, and we can go deep to the trigeminal nerve or even the petrous apex. We can treat lesions inside the orbit, or we can use the orbit as a surgical corridor to go to the optic nerve, internal carotid artery, the temporal pole, the lateral wall of the cavernous sinus, the middle fossa floor, or the frontofacial surface. And we can combine this approach with a standard approach. We define 4 surgical corridors specific for every lesion, and it is important to have a careful management of the soft tissues so we cannot damage this very specific area. Some pictures of the approach that we are using in these patients. This is a case with a complex lesion, wide lesion located in the central skull base, but reaching the lateral part to the anterior clinoidal process. So we perform a combined approach, transorbitary and endoscopic endonasal approach. As you can see here, we start with the approach in the orbit. So we gently retract the pre-orbit with the spatula advising the neuroanesthesiologist to be aware of any vasovagal reaction. And after that, we insert the telescopic drilling to have adequate exposure of the dura mater. Here we identify the lesser sphinal wing, in the superior part, the frontal dura, in the inferior part, the temporal dura, and then we are able to perform adequate decompression of the lateral part of this tumor. For the central part of the tumor, we came through the nose and performed the radical resection of the central part as indicated with no further complication. So the orbit can become a surgical corridor for some specific lesions that can be treated using this endoscopic technique. This is a postoperative MRI with a good clinical results. Another case, for a patient with a chondrosarcoma, we can also using endoscopic transorbital corridor. We will try to reach the most inferior part of the lesion. We start the dissection with opening of the frontal surface. We identify the sphinal ridge. In the inferior part, we identify the temporal pole and the anterior and the middle cranial fossa. Then we open the orbitomeningeal band. And once we reach the lesion, it is very easy to take out the tumor using ring curettes and tumor forceps to achieve adequate decompression of the tumor, as you can see here. So the orbit becomes the corridor alternative to the diurnal approach. We can see here the postoperative, immediate postoperative CT scan. We can use this approach also for the treatment of some very specific meningiomas or lesions located in the lateral wall of the cavernous sinus. So as this small lesion with the exophytic portion in the lateral wall of the cavernous sinus, the same history, careful retraction of the periorbit, identification of the frontal dura mater, the temporal dura mater, the sphinal ridge. And once we go inside, we can perform adequate peeling of the lateral wall of the cavernous sinus using the similar Dolench technique, but we are using instead the diurnal approach. We are using the transorbital corridor. Once we go inside, we can identify the lesion. We can take out the lateral portion of the tumor, and then we can go further and further using a tumor biopsy, ring curettes, or ultrasonic aspirator to take out the remaining of the tumor. Another case, a transorbitary endoscopic approach for the treatment of meningioma, very anterior located lesion, just straightforward in the transorbital corridor. So we perform again careful retraction of the periorbit, identification of the dura mater of the frontal basal part, identification of the temporal part of the dura, in the middle the sphinal ridge, and then here we perform early devascularization of the tumor because it's located in the temporal pole, and then we use the ultrasonic aspirator to decompress the tumor, and then we are very easily taking out the tumor once it is detached from the dura mater. Careful must be attended to perform adequate hemostasis and closure of this surgical corridor, taking in account that the orbit will cover the defect also, so the CSF fistula has not been present in these cases. We need to go a step forward in this technique, so we can go from extraconal extradural lesions to the most complex in the petrous apex or even the posterior fossa ones we have experienced. I can say that there is a clear need to embrace the specific techniques that provide the patient with a safe and health improving surgery. Both microneurosurgery and endoscopic techniques must be learned at the laboratory, and we need to learn that endoscopic techniques are just another method to access the different compartments of the central nervous system and must be used with a clear and strict clinical judgment. I thank you very much for your attention, and I'm open to hear your comments and questions. Thank you very much.
Thank you, Dr. Amador, for your very comprehensive introduction about the endoscope surgery for different kind of disease of neurosurgery. Yeah, I think you give us a very a nice introduction with your surgical experience. So thank you. Are there any questions from the audience?
Go ahead, Arshad.
Hi, John.
Hi, good day.
Really. Hello, Professor.
Could you please introduce yourself, Arshad?
Yes, I am Dr. Harsh Parekh, neurosurgeon from Mumbai, India.
Thank you.
This is a very amazing lecture. I have heard about the use of endoscope for various corridors and various types of lesions you can approach to the endoscope. I agree with you. Okay, you need to know the various anatomies and one should have a learning curve to reach to the various corridors. Wonderful. How do you approach the cavernous sinus directly, lesions which is lateral to the carotid artery, not the medial, transsphenoidal? Do you have any experience about that? The lesions which is lateral to the carotid artery.
Yes, sir. We have used the transpterygoid approach, ipsilateral transpterygoid approach to treat lesions lateral to the internal carotid artery, or we can use also the contralateral transmaxillary approach, so we can go behind the carotid artery directly without having the internal carotid in our surgical field. Now, with the use of transorbitary endoscopic techniques, we can see that this is just another corridor precisely to reach the lateral part of the internal carotid artery. So I think there are three different routes that we can use to treat lesions located in this region. We can go from the Petrus apex to the Meckel's cave or the pterygopalatine fossa using these very lateral approaches. We can use also the ipsilateral transmaxillary approach for some specific lesions also in these patients.
Wonderful, wonderful. What is the rate of complications you come across when you are working around the cavernous sinus, especially in terms of the cranial nerve palsies post-operative?
Yeah, the most of our experience is in the treatment of pituitary adenomas. And we have seen in our learning curve, at the beginning, we were using intraoperative neuromonitoring to address the function of a third, fourth, and sixth cranial nerves. And we have seen that for some reason, these nerves, even when the tumor is located in the cavernous sinus, they are displaced laterally and upward. So we have seen no damage using the neurophysiological monitoring to these cranial nerves. And I shared this experience with Fernandez Miranda and Prevedelo, and they have noticed the same. So when we are treating pituitary adenomas in the cavernous sinus, there is no lesion of the cranial nerves. If you perform adequate resection of a tumor, and as in most of the cases, the tumor is very soft, it is very easy to take out the tumor. When you have a fibrous type tumor or a chondrosarcoma, for example, or a chordoma in which your maneuvers are more extensive, then you need specifically for the sixth cranial nerve a very adequate monitoring and also even stimulation before to take out some parts of the tumor.
Do you always go to the cavernous sinus to remove the soft part of the tumor, like in cases of acromegaly? The tumor is extending into the cavernous sinus, or you just leave that behind and give by other option like SRS or a radiotherapy?
In our experience at the beginning, we were leaving this cavernous sinus portion. Then we started to know more the anatomy of this surgical corridor, and for functional pituitary adenomas, we perform more radical surgery. When we saw that it is a very safe procedure to be performed, now when we have non-functional tumors of the pituitary type in the cavernous sinus, we also go to the cavernous sinus because the tumor is open in the corridor. So we have the corridor already done, so we just need to go and take out the tumor. Careful must be addressed to assess the location of internal carotid artery, particularly when you're dealing with the posterior part of a cavernous sinus or the anterior part of a cavernous sinus. These are for me, the most critical steps in this part of the procedure. But I can say that at least for pituitary adenoma, it is very safe to go to the cavernous sinus using endoscopic endonasal approach. This is not the case, for example, for meningioma, in which we prefer the lateral route, but the transorbital endoscopic approach provides this lateral route also in the same manner as Dolench approach.
Right, thank you. And one more thing. Have you ever encountered any injury to the carotid artery?
Yes, sir. Yes, sir, and this is a very disastrous event. We have lesioned the internal carotid artery with scissors, with dissectors, with the monopolar needle, and also with the diamond drill. So usually the lesions in the internal carotid artery are very, very small, but the bleeding of a patient is in large amounts. So you need to address a neuroanesthesiologist to have induced hypotension in the time that you are trying to get some piece of muscle that we wrap in Surgicel and we put above the defect. We put a small gentle compression with the aspirator, and then we see the resolution of the bleeding, as I show in one of the videos. To my point of view, there is no better way to treat this lesion than with a muscle patch that we apply directly in the internal carotid artery. And we need to take the patient to the endovascular suite to address if we don't have cerebral aneurysm in the postoperative period, and also to perform an adequate control 3 and 6 months after the injury.
Right. Any experience of yours in your cases, you have encountered pituitary adenomas with aneurysm in simultaneous, in same patient?
Yes, I show you a patient, and we have other 4 patients with a coincidental pituitary adenoma and intracranial aneurysm. So this happened when we started to perform CT angiogram for the study of pituitary adenomas. So we have seen in the literature a range of 1 to 7% of pituitary adenoma associated with intracranial aneurysms, most of the times with patients with acromegaly, and these oncotic aneurysms can be treated in the same time, as I showed you before, either endoscopic endonasally or using a pterional approach to treat the lesion. It is important to know that the aneurysm is there, because if we are not aware of this, we can have sudden bleeding during the procedure, and this was due to an not identified intracranial aneurysm.
So you recommend that it is very important to do CT angio in all cases of pituitary cases?
I think so, because we can have a proper knowledge of the anatomy of the internal carotid artery in relation to the pituitary adenoma and the discovery of incidental aneurysms associated with these lesions.
We have encountered such thing. That's why I asked you. I have encountered myself when I was in trouble. And very right. Wonderful, wonderful techniques. You have got a great experience, and I must congratulate you for your vast experience in various corridors. Superbly demonstrated. Very good. Excellent. Thank you.
Thank you, sir.
Thank you, Harshad, for your probing question. I'd like to introduce you to Ahmad. Ahmad, are you there? I want to introduce Ahmad to Juan. Ahmad is the head of neurosurgeons in Afghanistan. Are you there, Ahmad? Perhaps not. Perhaps he's indisposed. Okay, very good. I want to show you. I want to show you something. Do you see the screen there? You see the screen of that? It's being.
Hi, John. I think we have the second speaker, right? Professor Liu.
Yes. Okay. Okay. Let me stop this. Okay. Yeah, this is. I'd like to introduce Ahmad. He's the head of neurosurgeons in Afghanistan. Hello, Ahmad.
Oh,
Hello.
hello.
Oh, very good. Okay, Juan Lee, let's move on.
Sure, sure. Let me introduce
you, Juan.
the second speaker, Professor Liu Yuqing from Beijing Neurosurgical Institute, Beijing, China. And today, she will talk about the clinical practice of molecular pathology detection in brain tumors. Yeah, Professor Liu, can you start your talk?
Okay. Thank you. Thank you,
Thank you.
Professor John. Yeah.
Perfect. Okay.
Can you see the PPT?
Yes, perfect.
Okay. Good evening, everyone. I'm happy to take a presentation, and today I will share a topic about advances in molecular pathologic detection of brain tumors. Okay. Next, I will introduce from the following four parts. First, I will introduce the molecular pathology of brain tumors. The molecular pathology is the science that studies the mechanism of occurrence, development, and outcome of diseases at the molecular level, and is a good supplement to traditional histopathology, and a necessary index for post-operative pathology and biopsy pathology at present. For example, when pathological diagnosis is oligoastrocytoma, namely mixed glioma, molecular pathologic detection can be used to finally determine whether it is oligodendroglioma or astrocytoma. Okay, next, I will introduce the application of molecular pathology in tumors of CNS. In 2016, the Blue Book, that is the WHO classification of CNS tumors, updated fourth edition was published. For the first time, the WHO classification of CNS tumors uses molecular parameters in addition to histology to define many tumor entities, thus formulating a concept for how CNS tumor diagnosis should be structured in the molecular era. Before 2021, the WHO CNS5 was published. During the 5 years, the impact now update the CNS classification for 7 times. The C-impact is the consortium to inform molecular and practical approaches to CNS tumor taxonomy. This is the 2016 WHO CNS classification, CNS tumors classification, and the red one, the red figure is a simplified organism for classification of the diffuse gliomas based on histological and genetic features. Take the glioma, for example. Only a few molecular signatures are involved, such as IDH mutant or YTAP, 8RX loss or not, TP53 mutation, and 1p19q co-deletion. Next, there is a brief introduction to the contents of the 7 updates. The update one proposed the NOS and NEC. NOS is not otherwise specified. It means specific WHO diagnosis cannot or will not be performed, or in which necessary diagnostic testing has failed, and the NEC is not elsewhere classified. That means the molecular results do not allow for a specific WHO diagnosis. The update 2, this update 2 contains two parts. The first, to diagnose diffuse midline glioma, H3K27M mutant. A tumor should be diffuse midline glioma and H3K27M mutant. This means that diffuse midline glioma, H3K27M mutant, should not be applied to other tumors that are H3K27M mutant, including ependymomas, pediatric astrocytomas, pediatric diffuse astrocytomas, and gangliomas, etc. And because these appear to have substantially varied clinical pathological features, that is, not forming a distinct entity, and not enough is known about the prognostic significance of finding H3K27M mutants in these other tumors. And another part is about the diffuse astrocytoma IDH mutant, or anaplastic astrocytoma IDH mutant. If there is loss of ATRX nuclear expression and or strong diffuse p53 immunopositivities, this can be diagnosed without the need for 1p19q testing. The update 3 is about the histologic grade 2 and 3 IDH wild-type diffuse astrocytic gliomas that contains one EGFR amplification or combined whole chromosome 7 gain and whole chromosome 10 loss, or third promoter mutations, should be referred to as diffuse astrocytic glioma, IDH wild-type, with molecular features of glioblastoma, WHO grade 4. Okay, update 4. Update 4 is about the IDH wild-type and H3 wild-type tumors. CIMPACT has reviewed the status of WHO grade 2 IDH wild-type, H3 wild-type diffuse gliomas, focusing on those with BRAF V600A mutation, FGFR1 mutation, or MYB or MYBL1 rearrangement, and recommends the use of an integrated diagnosis to combine their histologic and genetic features. For the update 5, the IDH mutant astrocytomas with microvascular proliferation or necrosis, or CDKN2A and B, homozygous deletion, or any combination of these features, correspond to WHO grade 4. These tumors have been formerly considered as glioblastoma, IDH mutant, WHO grade 4. However, they are clinically and genetically distinct from glioblastoma, IDH wild-type, and closely related to WHO grade 2 or 3 IDH mutant astrocytoma. Thus, C-impact recommends that the WHO strongly consider discontinue the term glioblastoma IDH mutant WHO grade 4 and instead recommends referring to these tumors as astrocytoma IDH mutant WHO grade 4. This is the update 6. In fact, the update 6 is a summary for the update 1 to 5. And the working committee recommended that a substantial number of newly recognized tabs and subtabs should be considered for inclusion in future CNS tumor classifications. In addition, the group endorsed a number of principles relating to classification categories, approaches to classification, nomenclature, and grading that the group hopes will also inform the future classification of CNS5 neoplasms. And this is the summary of the impact recommendations. The update 7 is for ependymal tumors. Separation of ependymal tumors by atomic site, they are posterior fossa, supratentorial and spinal compartments, and the molecular signature are distinct. And common recurrent genetic or epigenetic alterations found in tumors belonging the main molecular groups have been used to define tumor types at intracranial sites. Say 11ORF95 and YAP1 fusion genes for supratentorial tumors, and two types of posterior fossa ependymoma defined by methylation group PFA and PFB. A recently described type of aggressive spinal ependymoma with MECAN application has also been included. Combining the 2016 Blue Book and the 7 updates, the 2021 Blue Book was published. Further to advance the role of molecular diagnostic in CNS tumor classification, but remaining rooted in other established approaches to tumor characterization, including histology and immunohistochemistry. New tumor types and subtypes are introduced, some based on novel diagnostic technology such as DNA methylome profiling. Okay, this is a comparison of molecular signatures between the update CNS4 and CNS5 edition. In the update CNS4 edition, only a few molecular signatures were included in the tumor classification, while in the 5th edition, as many as dozens of new molecular pathological indicators are added, which poses a challenge to our molecular pathological testing work. Next, I will introduce our main testing items of molecular pathology. In the setting of WHO update CNS4, we have 4 platforms, and they are immunohistochemical staining platforms, parasequencing platforms, and fluorescence quantitative PCR and FISH platforms. We know that the fifth edition, that is the W2CS5, covers dozens of molecular markers, and different methods and platforms are required, which is time-consuming, labor-intensive, and higher costs. Therefore, NGS platforms are particularly required. Besides, maxillome profiling has been shown to provide powerful information for the classification and diagnosis of CNS tumors. Many CNS tumor types and subtypes can be reliably identified by their maxillome profile. As an important supplement to NGS, we retained these platforms such as parasequencing for the quantitative PCR and FISH platforms to verify some results of NGS if needed. This is the panel we the most panel for us to diagnose CNS tumors. The gene panel testing for precision diagnosis and treatment of CNS tumors, version 1. This contains only DNA and the molecular signatures DNA levels from DNA levels. This panel contains point mutations, insertions, and deletion of 52 genes, and contains copy number variation of 25 genes and six chromosomes of deletion and amplification. And now we are developing the second version, and that is the version 2. And this is the upgraded version of version 1. And all tumor types, molecular signatures of the W2CS5 classification are covered, including mutations, copy number variations, gene fusion, and gene rearrangement, etc. And the panel version 2 is expected to be applied in clinical practice next month. This panel includes gene fusion at the RNA level, compared with the version 1, such as PTPRC1 might, because this fusion genes is very important. Okay, the PTPRC1 mite is called ZM fusion, was first identified by our team, Jiang Tao's group. And the ZM fusion was found only in grade 3 astrocytomas, 7.7%, or secondary GBMs. It accounts for 55%. And then we found small molecular targeted drugs, PLB1001, that is baritinib. A new MET inhibitor, the PLB1001 baritinib, tested MET exon 14 and PTPR0 MET fusions. This shows preliminary efficacy for treatment of patients with secondary glioma. And the phase 1 clinical trial of the PLB1001 is effective for MET-altered gliomas, and the research result and these results are published in Cell. In November of the Brittany was a breakthrough in targeted treatment of MET-altered glioma. In November 2023, the Brittany was approved for indications of lung cancer, and it is expected approved for indications for glioma in June of 2024. The phase 2 and 3 clinical trial has been completed, and the relevant results are currently being compiled and prepared for publication. This is a good model for the transformation from basic research to clinical practice, that is from bed to bench to bed. Okay, next, the DNA methylome profiling. The methylome profiling is the use of arrays to determine DNA methylation patterns across the genome. For the WHO CS5, it is assumed that nearly all, but not all, tumor types are aligned to a distinct methylation signature, and is the most effective way for the unusual morphologic features, and maybe the only current way to identify some rare tumor types and subtypes. Besides, copy number profiles can also be derived from methylation data. The methylome profiling method is robust. Can methylation profiling replace the NGS? The answer is no, because in some conditions, such as methylome profiling, can't serve as a surrogate when targeted therapies and clinical trials require the demonstration of specific mutations prior to patient treatment. This is in the fifth edition of WHO classification of CNS tumors. Methylation profile is undesirable and essential diagnostic criteria for more than 55% of tumor types. And for some tumors, it is the unique diagnostic criteria. But the DNA methylation-based classification of CNS tumors. Accurate pathologic diagnosis is crucial for optimal management of cancer patients. The left figure shows the designation of 82 CNS tumor classes by DNA methylation-based CNS tumor classification. This method may have substantial impact on diagnostic precision compared with standard methods, resulting in a change of diagnosis in up to 12 of prospective cases. Look at the red figure. For 129 cases, and that is 12%. The 129 cases histologic and molecular assessment resulted in change of the initial diagnosis with formulation of a new integrated diagnosis. Okay, now I will introduce our testing flow and methods of molecular pathology. First, the sample collection and the pathological evaluation. Two parts, tissue section and the DNA extraction. They will through different methods, and finally we will obtain the histopathology report and the molecular pathology report. Finally, we integrated the report and obtain a layered report to assist clinicians in developing in developing the treatment of patients. Notably, the pathological evaluation of sample is extremely important because there is significant heterogeneity in brain tumor tissues. Only by selecting appropriate pathological tissues for molecular pathological testing, the accuracy and the credibility of molecular pathological reports can be ensured. And this is our neuropathological reports based on WHO CS5. The pathology report and the molecular pathology report, and then we obtain the integrated diagnosis report. The last part, the summary, a little summary. Accurate molecular pathological diagnosis required accurate tissue pathological diagnosis. The second, tumor cell amount and purity should be considered when interpreting results, including DNA methylation profiling and NGS. The third, even with many molecular testing methods now available, there are still 5 to 10% of cases in clinical practice where accurate pathological diagnosis cannot be made. The last one, due to the particularity of brain tumors, such as the influence of the blood-brain barrier, there are relatively few targeted drugs for brain tumors. We hope that molecular pathological results can guide more clinical experiments so that more drugs can be used for patients. That's all the contents. Thanks for your attention. Thank you.
Thank you, Dr. Liu, for your nice talk about the tumor, the brain tumor molecular pathology. Yeah, you gave us quite a lot of new information. So are there any questions from the audience?
Okay, I don't know if you
Sure.
have any. Thank you very much for the excellent presentation. Ahmad, do you have any questions or comments? Are you still with us there in Afghanistan?
Hello,
Hello.
Professor John. Thank you. It's very great presentation, and it was so good an update. Thanks very much.
Well,
You're
thank you.
welcome.
Mhm.
Okay, very good. If we have no more questions, I'd like to thank Juan Lee. Thank you for moderating, and thanks for the second speaker for speaking. And I'd like to say hi to Benzu in Little Rock, Arkansas. Okay, Juan Lee, we'll see everybody in 2 weeks.
Okay, thank you, everyone. Thank you
Thank
for
you very much.
Thank you.
for your attending. Yeah. See you
Okay,
next
we'll
time.
see you,
Thank
in
you.
a couple of weeks.
Yeah.
Thank you.